Hello everyone. So let us discuss about the anesthesia for a thoracic surgery. That is our one lung ventilation. This is a huge topic. So let us study it in a part-wise manner. So first let us learn about physiological consideration and what is this one lung ventilation actually. And next we'll take a case scenario. Might it be a bronchiectasis or a tumor case posted for resection? Might it be a segmental resection or the pneumonectomy? Till that, we'll know what is this one lung ventilation and all. Now we have to go for a preoperative assessment of the patient. And after that, we have to plan a technique to achieve this one lung ventilation. And then we'll study about intra-op and post-operative complications. Okay. So the first topic is physiological considerations. Here we'll learn about how ventilation, perfusion, and compliance changes with the position and also after induction. Okay, so ventilation and perfusion. Let us study in a scenario wise. First, the patient is awake and erect. Okay, in this scenario, our lungs will look like this, right? So, this is the apex, this is the base. The apex is the non-dependent region and your base will be obviously the dependent region. We know this. Okay. So from apex to base, think this is the apex and this is the base of the lung. This is the dependent region. The ventilation increases. That is, there is more ventilation at the base. What happens to the perfusion? The perfusion also increases from apex to base. That is more perfusion in the base because of gravity. What happens to the ventilation perfusion ratio? It decreases from apex to base. This we know from the physiology, right? So let us put it in writing. First scenario, ventilation perfusion in upper zone or apex in the lower zone. So this is non-dependent. This is dependent. Okay, ventilation is more in the lower zone and the perfusion is also more in the lower zone. So this is more compliant part. Okay, done. Now let us go for second scenario. This is the very basic scenario, first one. Next let us go into a different scenario. Second scenario, awake. And now the patient is in lateral decubitus position. Now what happens to the lungs? The lungs will be in this position, right? This trachea. Okay. So what happens to the ventilation perfusion now? This is the upper lung. This is the lower lung in a lateral position. That means one lung will lie above the other, right? So upper lung and lower lung. What is the dependent region? Lower lung. The non-dependent is the upper lung. So upper lung is the non-dependent, similar to this one. Lower lung is the dependent, similar to this one. Okay. So upper lung, lower lung. What happens to the ventilation and perfusion now? Ventilation is more in the lower lung and perfusion is also more in the lower lung. Why? First, perfusion is more in the dependent part because of gravity. And why this one? Because the contraction of the hemidiaphragm of this lower dependent lung is more effective than the non-dependent lung. So there is more ventilation here due to better contraction of hemidiaphragm. Okay, so this is awake and lateral decubitus. Now, let us go to the third scenario. The patient is awake. Okay, but sorry, the patient is in lateral decubitus but anesthetized. The patient is anesthetized and lateral decubitus. So the lungs remain, the position, orientation of the lungs remains same. Okay. So what happens to the ventilation and perfusion now? Will there be any change or not? Of course, there will be a change here that you have to remember is upper lung is obviously non-dependent and lower lung is dependent. There is no change here, right? How ventilation changes now? Actually, before the ventilation is more in the lower dependent lung. Now, what happens due to anesthesia? This contraction factor is not present. And also, all the abdominal contents, the diaphragm, will be pushed towards the thoracic cavity. So, there will be bean bag pressure effect. Okay, in the lower lung. So, there will be decreased ventilation here. And what happens to the perfusion? The gravity plays the role whether the patient is awake or anesthetized. So the perfusion remains same. It is more in the lower lung. So the ventilation is decreased and the perfusion is more in the lower lung in anesthetized patient. So here comes the ventilation perfusion mismatch. Okay, this you have to remember. Now let us go for the scenario, which is open pneumothorax. Of course, the patient is in lateral decubitus position, but now he is in awake state first. Okay, till now we have discussed in a closed thoracic cavity, right? So what happens? See, in lateral position, your lungs are in this way, right? So what happens now? There is an opening. So this lung is in direct contact with the atmosphere. Normally, what happens? There will be negative intrapleural pressure in the lungs, right? So, due to this opening, due to this direct contact with the atmosphere, this negative intrapleural pressure of the affected lung, that is upper lung here, is lost. So, what happens? This upper lung tends to get collapsed. So, it gets collapsed and the lower lung is normal. So, this is the position now. What happens? The patient is awake, he is taking spontaneous breaths during inspiration and expiration. What happens? What changes might occur? Okay, first, inspiration. Okay, so this is trachea. Now, there is more negative intrapleural pressure in the lower lung, and during inspiration, the negative intrapleural pressure increases. So, it takes or sucks the air into it. Apart from the atmosphere, the trachea, it also sucks the air from the opposite side. That means this one, from the opposite lung. So, apart from the air entering from the atmosphere, there is entry of air from the opposite or the affected lung also. So, what happens? The affected lung is getting shrinked or collapsed more. Collapsed. What happens during expiration now? Okay, this is inspiration. What happens to during expiration? The reverse. There is decrease in negative intrapleural pressure. So the air goes out and also towards the opposite lung, the affected lung. So the affected lung gets expanded now. Okay, this is during inspiration, this is during expiration. Okay. So normally what should happen? During inspiration, the lung should expand because it takes the air inside. During expiration, it expels all the air outside and it should shrink now. So it should expand here and it should collapse here. But the affected lung, it is exact opposite of this, right? So this is opposite. So what is happening is paradoxical respiration or pendulum effect. So this is a simple concept in open pneumothorax when the patient is taking a spontaneous breaths and he is having spontaneous respirations. During inspiration, there would be collapse, and during expiration, there would be expansion of the affected lung. Okay, so this should be avoided. So the patient has to be anesthetized. Okay, there shouldn't be any spontaneous breath. There is another scenario which is happening is mediastinal shift. Okay. Same. See, during inspiration, we said that there is more negative intrapleural pressure in the lower normal lung. So what happens? It pulls all the mediastinal contents towards its side. Previously, we saw it is taking in all the air from the opposite lung. Now it is pulling all the mediastinal structures towards its side. That means there is, during inspiration, there is shift of mediastinal contents towards lower side. See, during inspiration, the affected lung is getting collapsed, and also there is shift of mediastinal contents towards the lower side. What happens during the expiration? Reverse. So there will be pushing of the mediastinal contents towards the upper side. So this is nothing but mediastinal shift. So these two are the things that are happening in an open pneumothorax case. So paradoxical respiration and mediastinal shift, very much important and very easy. No need to by heart what is happening. So just remember the concept. Okay. So this is about the physiological changes. Now let us go into the second topic about one lung ventilation on a gross. Here, what we are doing is intentional collapse of one lung. So, there will be two types of lungs now, ventilated lung and the collapsed lung. Let us see the differences between both of them. The first one is collapsed lung. The second one is ventilated. So, what happens basically? In the collapsed lung, there will be no ventilation, right? But what about perfusion? Of course, there will be perfusion. So, there will be no ventilation and there will be perfusion. What will be the result of this? There will be shunting and unoxygenated blood. Okay, what about this ventilated lung? Here there will be ventilation and also there will be perfusion. So, there will be oxygenated blood. Right? Finally, these two will get mixed, forming hypoxemia. And there will be increased alveolar arterial oxygen gradient. Right? So there will be hypoxemia here. So we have to prevent this hypoxemia during the intraoperative period. So what will be our goal, or what we have to do is for the collapsed lung. So this is collapsed side. So this is collapsed and this is ventilated lung. Okay. So for the collapsed lung, we have to maintain the HPV. Okay. That means here we have to decrease the blood supply. There is no ventilation. So there shouldn't be any perfusion also. Otherwise, this unoxygenated blood will get mixed with the oxygenated ones, leading to hypoxemia. So we have to maintain HPV. So we have to decrease blood supply here. Okay, then what about this ventilated lung? For this, we have to have a good blood supply so that there is no hypoxia. So we have to maintain good blood supply here. We should not allow any decrease of blood supply in the ventilated lung, and we have to allow decrease in blood supply in the collapsed lung. So what measures we have to take is here, of course, we have to maintain HPV, or we can do surgical compression of the lung, or we can clamp the pulmonary artery which is supplying to this collapsed side of the lung. Okay, here what we have to do is we have to prevent HPV, we have to maintain blood supply, so and we have to prevent the conditions where there would be decreased blood supply to the ventilated lung. Okay, so what will be the problems? Again, this is collapsed side, this is ventilated side. Okay, what will be the problems here? For the collapsed lung, that is the side of the surgery, right? So there will be surgical induced trauma. Okay. What happens to the ventilated lung? Here the ventilation is by the ventilator, right? So there will be ventilator induced trauma. So here there will be ischemia reperfusion injury later. For the ventilated lung, there would be hyperperfusion. So both the lungs are being affected. For one, it is surgical trauma. For the other, it is ventilator-induced trauma. So both the lungs are undergoing stress here. So that we have to be very careful during both ventilation and collapsing the other lung. Okay. So next topic. How to achieve this one lung ventilation? So techniques. It is by double lumen tubes or bronchial blockers or the normal conventional ET tube directly into the main stem bronchus. That means if I wanted to ventilate the right lung, what I'll do? I will push the ET tube towards the right main stem bronchus. I'll push it further inside so that it will go into the right main stem bronchus and only that part of the lung, that right lung will get ventilated. Okay? Main stem bronchus and univent tubes. Okay? So these are the techniques. And among this, we'll be using DLTs, most common of the sizes available. So, fourth, next concept is indications. On a whole, you have to remember as patient related and surgery related. So, patient related and surgery related or any procedure related. In patient related, what will be our aim is to restrain the secretions or the blood into one lung. That means I don't want it to spread to other lungs. So I'll be going for one lung ventilation. So to retain the infected secretions or blood. What will be the surgical related causes? Any surgery in and around the lungs and the thoracic cavity. That means it might be lung related, which may be pneumonectomy, any resections, pneumonectomy or lobectomy, or the surrounding structures might be spine or the thoracic aorta, etc. Okay, so surrounding structures. Just to remember, let us go into detail later. So this is about indications. So the next is preoperative assessment. So we'll do the routine PAC. Normal, we'll take the history, we'll do for the airway examination, everything is the same. Okay, apart from that, here we'll have a specific assessment called three-legged stool test. That means here we'll be doing three main important parts of the assessment. They are respiratory mechanics, cardiopulmonary reserve, and lung parenchymal function. Okay, this is very important in one lung ventilation. So, if you have a question of this one lung ventilation, don't forget to write about this concept. Okay, so let us see one by one. First, let us go for respiratory mechanics. If you can't remember the whole theory given in the textbooks, please remember at least these some points. Okay, in the respiratory mechanics, what we'll see? FEV1, FVC, maximum voluntary ventilation, residual volume by TLC ratio, everything this we have already seen in the pulmonary function test. Okay, the main important is your FEV. Okay, so first we have to know the FEV1 of the patient. And next we have to predict the post-operative FEV1 also. then only we can know the prognosis or what we have to do post-operatively, whether we have to extubate the case or whether the patient will be a ventilator dependent or whether the surgery is really useful to the patient or not. Okay. So first we'll know the FEV1 and we'll predict the post-operative FEV1. Let us remember some numerics here. They are 2 liter, 1.5 liter, 1 liter, and 800 ml. Okay, so what are these numerics? If the FEV1, at least it has to be greater than 2 liters for pneumonectomy. So if you're planning for pneumonectomy, the preoperative FEV1 of the patient should minimum it has to be greater than 2 liter. And what is this 1.5 liter? FEV1 has to be greater than 1.5 liter for lobectomy. And what are these two 1 liters are? The postoperative predictive FEV1, if it is less than 1 liter, that means the patient after the surgery will be retaining the secretions. That means he cannot expel the secretions. So there will be secretions retainment, which is obviously a bad thing. And if the postoperative predictive FEV1 is still less, if it is less than 800, he will be ventilator dependent. Okay. So for these things, to predict the postoperative outcome, we have to know the preoperative and postoperative predictive FEV1. Okay. So how we will calculate the postoperative FEV1? First, we have to know the preoperative FEV1, and it goes by the formula FEV1 into 19 minus number of segments removed by 19. Okay, why this 19? Because the total number of segments are 19. How this 19 number has come? 10 plus 9. The right lung has 10 segments and the left lung has 9 segments, right? So, upper lobe, middle and lower. 3 plus 2 plus 5, right? For the right lobe. For the left lobe, upper lobe, lingula and the lower lobe. It is 3 plus 2 plus 4. So, total 9. And here 10, total comes to 19 segments. And here is another concept called post-operative predictive FEV1 percentage. Okay. So how to calculate this is pre-operative FEV1 percent. Here it is FEV1. Here it is percentage into 1 minus the fraction of segments of functional lung removed by 100 because it is a percent, right? So why this is useful? We have to see if this post-operative predictive FEV1 percent is less than 40 or greater than 40. Okay, if it is less than 40, it comes under risk category. So let us stratify the risk. If it is greater than 40%, okay, it comes under mild risk. Here I can plan on table extubation. I can, if everything goes normal. It is not 100%, but if everything goes normal, I can plan for on-table extubation. If it is between 30 to 40%, it comes under moderate risk category. Here, I can plan extubation on table if the other things are normal, like ventilation, perfusion, scanning, DLCO, everything. And if there are no other associated comorbidities, then I can plan extubation depending on the other factors. Okay. Might be ventilation, perfusion, or associated diseases. Okay. If it is less than 30%, the patient comes under high risk. And mostly the extubation or the weaning should be in a staged manner. Okay. Staged weaning has to be done here with appropriate analgesia. Okay. So this is how we will use the post-operative predictive FEV1 or the FEV1 percentage. Okay. Coming to this is the first part, which is respiratory mechanics. Let us go for the second part, cardiopulmonary reserve. So coming to the cardiopulmonary reserve, here we will be seeing VO2 max, the oxygen consumption. Normally to calculate this, we have discussed already in the pulmonary function test. So normally to calculate this, we have to know about exercise, heart rate, exercise, ECG, everything. So it is time consuming and it is not economic also, right? So in place of this, normally it has to be minimum greater than 20, right? In place of this, we are going to do some clinical tests. So normal will be greater than 20 ml per kg per minute. So what are the clinical tests that we can do are staircase test, shuttle test, 6-minute walk test, and exercise SpO2. Okay. So let us see individual things. First, staircase test. That means we'll ask the patient whether he can climb a particular flight of stairs or not. If he can go for greater than 5 flights, that means his VO2 max will be greater than 20 ml per kg per minute, which is obviously good. If he cannot do that, if he is not able to go for at least one flight, that means his VO2 max is less than 10 ml per kg per minute. Okay, so that is how we will portray this clinical test into VO2 value. Okay, so the second test, shuttle test. What happens here? Here we will be keeping 2 marks. Okay, and the 2 marks will be 10 meters apart. Okay, now we'll ask the patient to walk to and fro between these two boundaries or the marks and in an increasing speed. Okay, so we will calculate how many shuttles he is able to do. At least he has to do 25 shuttles. That means 250 meters because one shuttle is 10 meters, right? So at least 25 shuttles he has to do. If he is not able to do those 25 shuttles, his VO2 is less. Okay? These are simplified tests to know the VO2. The third thing is the 6-minute walk test. We'll ask the patient to walk a certain distance according to his capacity in 6 minutes. Okay, so let us see. Let us take that he has walked X meters in 6 minutes. Okay. So what we'll be doing is we have to divide that meters, that distance that he had traveled in 6 minutes divided by 20. It gives the VO2. That means if he has traveled 600 meters in 6 minutes divided by 20, his VO2 would be 30 ml per kg per minute. Okay, that is about the 6-minute walk test. Finally, about exercise SpO2, it is nothing but we'll measure the SpO2 first and we'll ask the patient to do some exercise and then we will see the drop in the SpO2. If the drop in the SpO2 is greater than 4%, that means the patient is of high risk category. Okay, this is about the clinical tests to know about the VO2. That is, finally we'll know about the cardiopulmonary reserve. This is nothing but cardiopulmonary exercise test. Okay. Next, the third test is lung parenchymal function. So the best test to know this is DLC. It is same. The formulas, everything are same as that of post-operative predictive FEV1. That means first we'll know the pre-operative DLCO, and now from here we will predict the post-operative DLCO. Same like that of post-operative FEV1. Okay, so post-operative predictive DLCO is pre-operative DLCO into 19 minus number of segments removed by 19. The percent is also same. DLCO percent into 1 minus fraction of functional segments removed by 100. So again, if this post-operative predictive DLCO percent is less than 40%, there is increased risk. Okay, so these are the three tests. Three-legged stool test, that is respiratory mechanics, cardiopulmonary reserve, and lung parenchyma. In the mechanics, we'll be seeing more about FEV1. In the lung parenchymal function, we'll see about DLCO. And in the cardiopulmonary reserve, we'll see about cardiopulmonary exercise testing so that we can know VO2. And it is a little tough test to do. So we'll be going for little easier clinical tests like 6-minute walk test, shuttle test, staircase test, and exercise dispute. Okay, so this is about pre-operative assessment. Apart from this, the routine investigations, obviously we have to have like virals, CBC counts, LFTs, RFTs, ECG. Okay, the main important things are we have to have HRCT chest, 2D echo, pulmonary function test, and baseline ABG. These are specific and you should not forget among the routine investigations. Okay. Now, later, preoperative optimization. So I have assessed the patient. I have done all the tests. Now optimization, obviously. So what you wanted to optimize is, obviously I have to have lesser secretions. The volume of secretion should decrease. The cough has to decrease depending on the etiology. And whatever the secretions, they should be less purulent. Right? So what are the measures I'll take? Smoking cessation. Smoking cessation. Mucolytics. Bronchodilators. Adequate antibiotics. And apart from these drugs and all treatment, adequate hydration plays an important role. Okay, now I have optimized my patient. Now I'll take him to the OT. So, what will be my plan of anesthesia? Obviously, my plan will be general anesthesia with thoracic epidural analgesia. Right? And in this general anesthesia, I'll go for one lung ventilation. Keeping this one lung ventilation beside, so the normal things in general anesthesia will go for pre-medication, induction, and maintenance with neuromuscular blockade. Right? So, during pre-medication and induction, while giving sedatives and all, I have to be careful to prevent the aspirations, and also we have to induce in a secretion retaining position. Okay. So, secretion retaining position should be maintained. Routine, obviously the patient will be in NVM status. So we need not worry that much about aspiration, but routine aspiration, anti-aspiration measures will be taken, and we have to see that secretions will not, okay, infect the other normal lung. Okay. The next thing in the maintenance and neuromuscular blockage, see that there is no histamine release. So we have to avoid atracute. So we can go for vecuronium or rocuronium and modest inhalational agents, and we have to prevent halothane. Okay. Here in the induction, we can go with propofol with remifentanil. Better. Okay. If remifentanil is not available, we'll obviously go with fentanyl. But we should not go for higher doses. Okay. Next. So what are our goals? Goals during this one lung ventilation. Okay. So we have to have adequate collapsibility in the collapsed lung. Okay. We have to have adequate collapsibility. Here in the ventilated lung, we should prevent atelectasis. Right? So what we have to do, adequate denitrogenation has to happen before the before collapsing the lung. Because before collapsing the lung, if the lung contains nitrogen or air mixed with oxygen, it will take time to collapse, right? Okay, the oxygen, the nitrogen takes time to come out. Okay, because of its blood gas solubility coefficient. So we have to adequately denitrogenate the patient to have maximum and fast collapsibility. And here we have to go for recruitment maneuvers so that the ventilating lung will not have atelectasis. Okay, here we have to use recruitment maneuvers. So we know the goals of one lung ventilation now. So let us see any case. Let us see if a case of bronchiectasis. Before that, first let us see this. Any case of bronchiectasis or any tumor posted for lung resection surgery. So this is our case now. Let us see what we have learned till now and let us go further. One second. Okay, let us see what we have learned till now so that it would be a quick revision before going to techniques of one lung ventilation and also the complications, intraoperative and postoperative complications. Okay. So first we have learned about physiological considerations, right? So in awake erect patient, what will be the ventilation and perfusion? And in the awake lateral decubitus position, what will be the ventilation and perfusion? Next, in anesthetized lateral decubitus, there will be ventilation perfusion mismatch. And if till now it is closed to thoracic cavity, and if it turns into an open pneumothorax, we have two important concepts called mediastinal shift and paradoxical respiration. In mediastinal shift, what happens during inspiration? There would be downward shift, and during expiration, there would be upward shift. All this is because of negative intrapleural pressure, which is more on the normal dependent lung. So next, coming to paradoxical respiration, it is also known as pendulum effect. In this, what happens during inspiration in the affected lung, the actually during inspiration the lung has to expand, but in the affected lung the lung is being collapsed. So it is reverse of the normal what should happen. So it is called paradoxical respiration, and it has to be prevented by anesthetizing the patient. Let us see in the diagrammatic form. So the first thing is mediastinal shift. Here there is more negative intrapleural pressure. So it is dragging all the contents towards its side. So during inspiration, which the negative intrapleural pressure still increases, and thus the mediastinum shifts towards the downward or the dependent side. Exact opposite happens in the expiration. Coming to the second effect, it is paradoxical respiration. See, this is inspiration, and here the air is being sucked into the normal lung, both from the trachea atmosphere and also from the opposite lung. So the air goes here, causing collapse of the affected lung and expansion of the normal lung. So, getting collapse during inspiration, it is reverse. So, it is paradoxical respiration. So, coming to one lung ventilation, there is intentional collapse. So, there are two types of lungs here, collapsed lung and the ventilated lung. In the collapsed lung, there would be no ventilation, and in the ventilated lung, there would be both ventilation and perfusion. So, the problems which might happen in the collapsed lung are surgical trauma and ischemic reperfusion injury, whereas the problems in the ventilated lung are hyperperfusion and ventilator induced lung injury. So what I have to do for collapsed lung is blood flow should be decreased. So what are the conditions where the blood flow can be decreased? That HPV should be active here. Okay. So HPV has to be active here, and there will be, we can go for surgical compression of the lung or clamping of the pulmonary artery, and we have to prevent decrease in HPV here. So what conditions we have to avoid? There shouldn't be any pulmonary hypertension or increase in carbon monoxide. We shouldn't use or go for any vasodilators or PDE inhibitors, beta agonists, and calcium channel blockers, or inhalational anesthetics in a more quantity. Okay. Coming to what to do for ventilated lung, that here the blood flow decrease should be avoided. So we shouldn't go for more airway pressures or more PEEP. Okay. Again, we shouldn't decrease the FiO2 too much, because it may activate HPV, and we should not have HPV acting in the ventilated lung, because HPV is nothing but hypoxic pulmonary vasoconstriction. So due to this vasoconstriction, there will be decreased blood flow in the ventilated lung also. Okay. We shouldn't go for more intrinsic PEEP and vasoconstrictors. Okay. Coming to indications, we have already studied. We have to remember on a gross, like patient related and procedure or surgical related. Patient related are due to confine the infection or bleeding to that particular lung. Okay. So you can take a picture of these indications so that you can buy heart. Okay. Coming to techniques, double lumen tube, single lumen tube, conventional ET tube directly into the mainstem bronchus, and the fourth one is univent tubes. We'll learn about these tubes later. So we are taking a specific case, might be a bronchiectasis or tumor. Bronchiectasis is nothing but abnormal and irreversible dilatation of a part of bronchial tree, whether it may be segmental or subsegmental. On a gross, just to know what is this bronchiectasis or what types of tumor that can occur in the lung. This is a theory part. Just you can take this screenshot or picture also regarding the etiology. It might be infectious causes and non-infectious causes. Infectious causes again can be bacterial or viral. Okay, non-infectious causes may be due to aspiration or obstruction. Okay. So, which patients are more predisposed to this bronchiectasis are immunocompromised if he is having any ciliary motility disorders or mucus secreting disorders. Okay. Half the patient might present is, obviously we can go for respiratory symptoms, like he'll have productive cough, purulent sputum, frequent respiratory tract infections, hemoptysis, and weight loss or fatigue. And what we can observe in the patient are Krebs, wheeze, clubbing, and signs of pulmonary and right ventricular failure. Okay. Coming to the second, this is which is tumors. Again, you can take this screenshot, because this is to just to by heart or remember just on a gross. Okay. There will be, obviously, tumors are two types, benign and malignant. In the lung, there benign include hematomas and bronchial adenomas, whereas malignant type include small cell and non-small cell. Again, non-small cell is divided into squamous cell tumors, adenocarcinoma, and large cell carcinomas. Okay. So preoperative evaluation, this is very much important, which is three-legged stool test. Okay. This includes respiratory mechanics, cardiopulmonary reserve, and lung parenchymal function. Firstly, in respiratory mechanics, we'll see FEV1, FEC, maximum voluntary ventilation, and residual volume by TLC ratio. So this will be both will know for FEV1 and also percentage post-operative predictive FEV1%. Okay, these numerics we have already learned, and this less than 40% are at increased risk. Okay, so this one we skipped. There is a thing called predictive post-operative product. Okay, it is nothing but we have calculated post-operative FEV1% separately. We have also calculated post-operative DLCO% separately. Its product is nothing but predictive post-operative product. Okay. If it is less than 1650, there will be increased complications. Okay. So we'll go to next. So this is a post-operative predictive FEV1. We have already learned the formulas. These are about segments. This is about the percentage post-operative predictive FEV1% if it is greater than 40%, between 30 to 40, and less than 30%. Mild, moderate, and high risk. Okay. The second one is lung parenchymal function. Here we'll see DLCO, right? Again, the same post-operative, we'll predict post-operative DLCO and post-operative predictive DLCO percentage. What this DLCO actually says is, it tells about the alveolar capillary exchange. Okay. What exchange? Oxygen exchange. Gas. So next we'll go for cardiopulmonary reserve. It is nothing but we'll go for cardiopulmonary exercise testing, which is the gold standard. Here we'll know about the exercise ECG, heart rate, and minute ventilation and oxygen consumption of the patient. Okay. This thus calculated the maximum oxygen consumption is a little bit time consuming and cost ineffective. So we'll go for clinical test. So normally if the VO2 is less than 15 ml per kg per minute, the patient goes under risk. And if it is still less, if it is less than 10 ml per kg per minute, the risk goes on increasing. Coming to clinical tests, we have seen 4 clinical test rates. So stair climbing test, 5 flights, it's greater than 20 ml per kg per minute. 2 flights, it is between 12 to 16 ml per kg per minute. And if it is less than or equal to 1 flight, it is less than or equal to 10 ml per kg per minute. Okay. Shuttle test, we already saw that it will we will keep 2 markers, which is 10 meters apart. And the patient is asked to walk to and fro. And if he can go for 25 shuttles it is good. If he cannot complete 25 shuttles, that means his VO2 is less than 15 ml per kg per minute. Coming to 6-minute walk test, he will ask him to walk a distance that he can in 6 minutes. And if it is nearly equal to 600 for suppose, the distance walked by him is x or 600 meters for suppose, we'll divide it by 30. So it will give VO2 of 20 ml per kg per minute. Okay. The final thing is exercise SpO2, and if the decrease in SpO2 is greater than 4%, it means the person is under risk. So apart from this 3-leg stool test, the routine investigations, the specific investigations, we have some other tests called ventilation perfusion scintigraphy and ventilation perfusion scanning. Okay, coming to ventilation perfusion scintigraphy, it is nothing but will give some radioactive substance, might it be inhalation of radioactive xenon or IV technetium. Okay, this will go into the body and this will be taken up by the lungs also, right? So we'll have gamma cameras and computer to calculate how much uptake is taken by the lungs and specific segments. Okay, so we'll know the percentage of radioactivity taken by each lung or segment or part. What we'll know by this is all the segments will be taking the radioactive substance. So we know the region of lung resection. Okay, so if the lung segments take more of this radioactive substance, means it is better functioning, right? Okay, so we'll get a computer calculated picture of what are the parts of lung which have taken more uptake and which have taken less uptake. In this, we'll see what is the part of lung we are going to resect. By that, we can know what is the function of the lung which is being resected and also which is being left out. Okay, so that we can know post-operative functioning of the lung. Coming to ventilation perfusion scanning, we'll do this if the post-operative predictive FEV1 or DLCO is less than 60%. And here there is a formula to know the expected loss of lung function, which is preoperative FEV1 into the percentage of function of affected lung. Okay, that means some part of lung is affected, and how much percent it contributes to the total functioning of the lung. It will calculate that in percentage form, and that multiplied by number of segments removed or resected, the total number of segments in whole. Okay, this is another form. And till now we have seen about lungs and combined cardiopulmonary reserve. Coming to actual assessment of cardiac risk, there is an index called thoracic cardiac risk index. Okay, there are certain points here which are if the patient is having any history of CAD or cerebrovascular disease, and if the case is being posted for pneumonectomy, and if the serum creatinine is greater than 2 mg per dl. Each will have certain points. All three, above 3 are 1.5 points each, and the serum creatinine point is 1 point. That means the overall score will vary between 0.5 to 5. And this is graded again in the classes of A to D. That means A, B, C, D. Okay. So in this score, if the score is greater than or equal to 2, that means cardiac function is not good and it has to be optimized prior to the surgery. So this is thoracic cardiac risk index. First, we have learnt about the routine test, specific test, 3-leg stool test, and the other tests include ventilation perfusion scintigraphy, ventilation perfusion scanning, and thoracic cardiac risk index. And in that, the numerical that you have to remember is if the index is greater than or equal to 2, you have to optimize cardiac condition also. Okay. So this regular preoperative preparation, cessation of smoking, this we have already learned: antibiotics, bronchodilators, steroid therapy, mucolytics, hydration, physiotherapy. And if he is having hypogammaglobulinemia, we have to go for IVIG, and regular vaccination we have to follow. So that our aim is that the disease should be localized and the volume of sputum has to be decreased, and sputum shouldn't be purulent, and secretions are not foul smelling. This is a preoperative optimization. Okay, this can be asked as a question in Viva also, so please remember. And these routine investigations and specific investigations we have already seen in CBC. There might be increased WBC counts due to infection. In ECG, you can have features of right ventricular failure, P pulmonale, RV strain pattern, or right bundle branch block. And we should definitely have a 2D echo done to rule out this RV dysfunction and pulmonary arterial hypertension. This hypertension will play a role during ventilation, right? We have seen it already. And we'll see for chest x-ray. And of course, the investigation of choice would be HRCT chest. And we'll go for PFTs. We have to know whether the etiology is causing an obstructive or restrictive pattern of lung disease. And ABG, because we have to know the baseline oxygen saturation, oxygen levels, PO2 of the patient. So technique, obviously general anesthesia with thoracic epidural, and will achieve the one lung ventilation by lung isolation by using DLTs or bronchial blockers mainly. The others would be direct convention ET tube directly into the mainstem bronchus or the univent tubes. The routine monitors pulse oximeter, NIBP, ECG, ETCO2, temperature, and also we'll go for intraarterial blood gas monitoring. So we'll have an arterial line also, and pulmonary arterial catheter if it is feasible, urine output, and transesophageal echo. Coming to anesthetic technique, we have already seen that by using sedatives and respiratory depressant, we have to be careful because again the secretions may contaminate the other lung also, and we have to do all this procedure induction of the anesthesia in secretion retaining position. Okay. Next, induction, propofol and remifentanil, we have seen it. And if it is an elderly patient or if he is having any cardiac issue, we have to go for etomidate. And neuromuscular blocking, in that we have to avoid histamine releasing drugs like etracurium. So we'll go for vecuronium or rocuronium or cisatracurium. And we have to avoid drugs which decrease HPV, and we have to avoid halothane. And in patients with bullae-Einstein, please remember we should avoid nitrous oxide. Okay. So our goals, we have learned it already that we have to have good collapse of the non-ventilated lung and avoid atelectasis of the ventilated lung. For that, what we have to do? Adequate denitrogenation, and for the ventilated lung, we have to go for recruitment maneuver. And the second important goal is regarding positioning. These goals are apart from your adequate hemodynamic monitoring, proper hemodynamics, and treating intraoperative hypoxemia and other complications. Keeping them aside, because we already do it for routine procedures, and also intraoperative hypoxemia will be separate topic discussed later. So I'm concentrating on the other goals, including adequate collapsibility, adequate recruitment of the ventilated lung, adequate collapsibility of the collapsed lung, and also positioning, because in this we'll go for lateral decrepitous position and see that the shoulders are adequately placed and adequately padded, the legs, and there is a pillow between both the legs, and there is axillary roll, and all pressure points are adequately padded. Okay. Coming to the next topic, complications. What major complications I might expect is any compression injuries, or arrhythmias. And the third one, intraoperative hypoxemia. This is very much important because this can be asked as a separate question. Okay. So let us see about compression injuries. We anticipated this compression injuries, and previously we have taken care that the whole pressure points are adequately padded. What compression injuries I might expect are regarding to plexus or nerves, or vessel compressions, or any organ like eye compression, compression of the eye. Okay, eye compression. So these three compression injuries I can expect, and I have taken care in the goals that I have adequately padded and I have adequately done the positioning of the patient. Okay. The second one is arrhythmias. The arrhythmias may be intraoperative or postoperative. By intraoperative, during dissection, there might be stimulation. Okay. By postoperative, during mobilization, there might be increased sympathetic stimulation that might lead to arrhythmias, or due to increased pulmonary vascular resistance. Why pulmonary vascular resistance has increased? Due to resection of lung or any strain or any stress to the right side of the heart. Okay, so arrhythmias intraoperative and postoperative. Intraoperative is due to stimulation and postoperative due to mobilization or increased PVR. Then the next important topic is intraoperative hypoxemia. Okay. So, why this intraoperative hypoxemia might occur? We have already learned that due to shunting. Okay, because one lung we have collapsed and it is not being ventilated, but it is being perfused. We have taken measures to reduce that perfusion. But if that measures fail, there might be intraoperative hypoxemia. What you will do if there is intraoperative hypoxemia? First, I will check the tube, whether the bronchial or the endotracheal tube, which might be DLT or any other tube that you have opted for the one lung ventilation, is in place or not. First, you check the tube, check the position. This routinely for routine intraoperative hypoxemia also will do this. Next, you will increase FiO2 to 1. That means you'll cut off all the gases except the oxygen. Next, for ventilated lung, what you have to do, and for the collapsed lung, what you have to do. For the ventilated lung, you have to see that you are giving adequate PEEP, and you have to go for recruitment maneuvers. For collapsed lung, you have to see whether there is decreased shunting or not. That means whether there are any factors which are decreasing HPV, like your inhalational anesthetics. So you cut off the factors that decrease the HPV, first thing, or you give some oxygen or the CPAP to that collapsed lung. Or the third thing, if all the measures fail, you restart the dual lung ventilation. Okay, so you will be ventilating both the lungs now. And most importantly, if the patient is a COPD patient, you have to rule out any pneumothorax, which might be the cause of your hypoxemia. So these are the complications: compression injuries, arrhythmias, and intraoperative hypoxemia. Next topic is, so what is the, how do you achieve this one lung ventilation? That is the prime topic, right? So we have already discussed there are four ways. First, in that four ways, let us see the first one: double lumen tubes. Again, this double lumen tubes might be a separate question, or it may be asked in Viva as a spot. Okay. So first, subheadings is, what are the types of double lumen tubes you know? That may be Carlin's, Robert Shaw, disposable double lumen tubes like that of we use as PVCs. And the next one are the newer modifications in those double lumen tubes, like they're having a radiological marker at the cuffs. Okay, newer improvisations. Okay, so Carlins and Robert Shaw are the older types. What you have to know is Carlins has a carinal hook. See, car. So please remember this one thing: carinal hook. So what does this Robert Shaw has? This Robert Shaw has larger lumen. Okay, so Carlins has a carinal hook and the Robert Shaw has a larger lumen. These 2 points you remember so that we can add additional points. See, this has larger lumen. That means the previous Carlins has a smaller lumen. So it will have high flow resistance. Okay, this has carinal hook. So this has no carinal hook. So for Robert Shaw, they have removed the carinal hook, and what change has been done for Robert Shaw is it has a larger lumen. Okay, so these are the two older tubes that you have to know. Next, the other division might be right-sided. This is one division, and left-sided double lumen tube. Okay. So, what is the speciality of this right sided? Obviously, we'll be using left sided double lumen tube more frequently, and that is a easier way. Why? Because right sided double lumen tube should have a side port. Why? To ventilate the right upper lobe bronchus, because the right upper lobe bronchus gets, after the division of trachea into the two main bronchus, the right upper lobe bronchus is immediately the right bronchus gives the right upper lobe bronchus very fast. So it has to have a side port which should ventilate the right upper lobe bronchus also, right? So generally see, this is right, this is left, you will immediately get a right upper lobe bronchus. So if your tube goes inside till here, this upper lobe won't be ventilated. So it has to have a side port here so that the right upper lobe also gets ventilated. Okay. So it has to have a side port where we have to use this right. Generally, we use the left DLT, right? So where you have to use the right is when left is not feasible. That means you cannot pass the tube in the left main stem bronchus. So there is a tumor in the left main bronchus. Okay, or there is anatomical distortion. Okay, or the surgery is at the left main bronch. So when you are going to use the right main bronch, right DLT is when you're not accessible to the left main bronchus. Examples are the surgery is going on the left main bronchus, there is a tumor on the left main bronchus, or there is anatomical distortion. Okay, this is about the types of the DLTs. Now, the next topic in the DLTs, advantages, disadvantages. What are the advantages? It is easier. The method of insertion is easier, and you can change the side of the one lung ventilation at any time. Okay, so you can change the side of the one lung ventilation because I have planned for a right lung ventilation. That means I want right lung to be ventilated. Suddenly, I changed my mind due to some reason. I want left lung to be ventilated and right lung to be collapsed, or I want a dual lung ventilation. Anything can be done with this DLT. Okay, what are the disadvantages? All sizes are not available, and next, it might cause trauma. So, iatrogenic injuries might happen with the DLT. And the third thing is, it is not suitable for post-operative ventilation. So during that, when the DLT is inside, I can opt for either both lung ventilation or one lung. I can also do bronchoscopies. I can do suctioning. Everything is feasible. Okay, but it is not that feasible for the post-op ventilation. So these are the advantages and disadvantages. So method of insertion. Methods of. So first you have to know how to insert. Then you have to know how to conform and at what size you have to select and at what depth you have to insert. So, method of insertion, size, coming to size, according to height and sex, according to tracheal width. Okay. So, the most commonly used sizes are 35, 37, 39 and 41. Okay. Just remember female and male. Female, male. Okay. Females less than 160 centimeter height, greater than 160 centimeter. Males less than 170 centimeter height, greater than 177 centimeter. So at least this criteria, if you remember, it will be easier. See, 35, 37, 39, 41. First two are for female and the next two are for male. Less than 160, greater than 160. Less than 170 and greater than 170 for males. Okay. Coming to tracheal width. If you know the tracheal width, either by a chest X-ray or HRCT chest, okay, then according to that width, you can select the size of the DLT. So, if the tracheal width is greater than or equal to 14 mm, you'll go for 35. Greater than or equal to 15 mm. Greater than or equal to 16 mm. Greater than or equal to 18 mm. Please remember, that is not 70. Okay. So, either by height and sex or the tracheal width. Okay. This now we have selected one size of the DLT. So, size part is done. Coming to depth. At least before insertion, I'll have one number in mind that at this depth, I have to insert the DLT. So, second is depth. So there is a formula for depth of insertion. It is height in centimeter plus 12 by 10. Okay. So this is a formula for depth of insertion. Okay. Next. So depth is done. Coming to methods of insertion. And later we'll go for confirmation. So there are three methods of insertion. There are two methods of insertion, blind or fiber optic. Okay, first let us go for blind. What you'll do in blind? Simply, you will induce the patient, you'll give the muscle relaxant, now you'll do the scopy and you'll see the cords, right? Now, let us imagine this is a DLT. There will be a curvature at the end of the DLT. So you hold the DLT in such a way that this curvature is concave anteriorly. Okay. So now the curvature is concave anteriorly. I'm seeing the cords. So I'll insert into the glottis vein. Because these are the vocal cords. I'll go into the vocal cords. One, I reach the glottic opening. Now I'll rotate this DLT in 90 degrees towards the side in which I have to intubate this. Okay. So if I wanted this side, I'll rotate towards this side. Okay. So I'll rotate and I'll go further till resistance is felt. Or my my SS depth is attained. So I'll have some number in mind regarding the insertion depth. So I'll go till that depth or till I feel some resistance. Okay, this is blind method. So first you will hold the tube such as it is concave anteriorly. The curvature is concave anteriorly. Okay. First you'll do scopy, laryngoscopy. You'll hold the tube as such that curvature the tip of the DLT has a curvature at the tip, so it has to be anteriorly concave. Okay. Now you'll go into the glottic opening. Now you will rotate 90 degrees towards the side which it has to be intubated, and next you will go further till resistance is felt or the depth, the number which you have in mind, depth is attained. Okay, this is blind. What about fiber optic? Till here, it is same. First, you'll go for laryngoscopy and you will insert the tube till the glottic opening. This TLT has to be inserted with the help of stillet. So, in both types, both ways, you'll have a stillet. In fiber optic method, till here you'll have stillet. Now, after entering the glottic opening, you will remove the stillet. And from here, you will insert the fiber optic scope, fiber optic into the DLT. See, this is, for suppose this is the DLT, till now there is a stillet. Now you will remove the stillet and you will keep the fiber optic bronchoscope here. Okay. Your flexible fiber optic bronchoscope will be inserted into the tube. And now the insertion depth is guided by this fiber optic. So this is DLT. I'm removing the slit. I'm keeping the fiber optic bronchoscopy, and the depth of insertion is guided by this fiber optic, because you'll be visualizing in the screen till where I have reached, whether it is carina or I have reached into the right bronchus, whether it is right at the level of right upper lobe bronchus, everything will be visualized in the screen. Okay, so till here there is stillet. Now there is fiber optic flexible bronchoscopy, and instead of this, the conformation is visualization. These are the two methods of insertion. Now, how you will confirm? Confirmation. Again, this confirmation is by three methods: auscultation, fiber optic, or ultrasound. Fiber optic we have already learned. And what is this ultrasound guided? One lung will be collapsed during this one lung ventilation, right? So I'll insert the DLT whether by blind approach or the fiber optic. If it is by fiber optic, it is an additional confirmation. Ultrasound will be an additional confirmation. So I'll be ventilating. So only one lung has to ventilate and other lung will be collapsed. So in the collapsed lung, if I do ultrasound, there will be no lung sliding. Okay, this we have to see. So coming to auscultation, it is a little different from our regular auscultation. Okay, so first DLT will have two lumens, tracheal and bronchial lumen, and two cuffs, tracheal cuff and bronchial cuff. Let us see in the form of a diagram. See, this is a DLT being inserted. First, it is concave anteriorly. So after reaching the glottic opening, we have rotated it 90 degrees, and these are the two lumens. See, this is tracheal lumen. This is bronchial lumen. This is tracheal cuff, and this is bronchial cuff. Okay. Now, what I'll do, I have inserted and I wanted to confirm it by auscultation. Now, I will inflate the tracheal cuff. Now I'll ventilate. What should I hear? I have to hear breath sounds bilaterally. Okay, because this is inflated as the now it is like normal endotracheal tube. Okay, so I have inflated here. I'm ventilating it through the tracheal lumen. Both the lungs will get ventilated. Now I'll inflate the bronchial cuff also. Now I'll clamp. I'll clamp this side. That means I'm clamping bronchial lumen. Okay. Now what I have to hear? I have inflated both the cuffs and I have clamped bronchial lumen. So whatever ventilation goes, it will reach here. So in this scenario, all the ventilation is reaching here. It will obviously enter this side. So I have to hear unilateral breath sounds. Why I'm not hearing the opposite side? Because there is a bronchial cuff here. It is obstructing the path. So whatever ventilated air is reaching here, it is going here, but it cannot enter this because of this cuff. It is like an obstruction. This is when you block the bronchial lumen. Now, let us see another scenario. Now I'm clamping tracheal lumen. This bronchial lumen is open. Both the cuffs are inflated. Now, whatever the ventilated air goes directly and opens here. So, whatever air is present here, it ventilates this side of the lung. The air which comes back is again obstructed because of this bronchial. So, again, it is contralateral. Unilateral breath sounds has to be heard. Okay. So understood which side is separate scenario. What if I keep this DLT this side? The opposite happens. When the tracheal and bronchial lumens are clamped, the opposite happens. Simple. Just you remember that. First, we'll inflate tracheal cuff. We'll see the bilateral air enter. Next, we'll inflate the bronchial cuff. And now we'll clamp each lumen and check for unilateral air enter. Okay? So that is auscultation. So DLTs might be separate question, right? So you have to know the types of DLTs, size to be selected, depth of insertion, and method of insertion and confirmation. Okay, let us go into the theory part. If we have missed anything, and regarding the diagram. So the first is DLTs. We have seen Carlins, Robert Shaw, and disposable DLTs made up of PVC, and other improvements are there, including radiological marker near the both endobronchial and endotracheal cups. These are the diagrams. This is Robert Shaw and this is Carlins, and there is a carinal hook here. So again, there are two types in each LT, right and left. What are the advantages? They are easier to place. We can go for bronchoscopy, suction, and CPAP can be applied, and we can alternate the one lung ventilation to either lung. Once I have thought of right lung ventilation, now I can alternate it with left lung ventilation also. But what are the disadvantages? Site selection is difficult, and it is difficult to place in difficult airway situation. Okay. And it is not ideal for post-operative ventilation, as we have seen. And it may cause iatrogenic traumas, airway injuries, unexpected air leaks, and subcutaneous emphysema due to trauma. Okay. And these lumens are relatively smaller than the usual ET tubes that we use. Size of the DLT selection we have seen according to the numbers, and the placement should be in such a way that the bronchial cuff is just below the carina. See, this bronchial cuff should cross the carina, and this tip should be above the upper lobe bronchus. Okay. First, we have seen that bronchial cuff should cross the carina. So I have inserted this till here. I have gone into one of the bronchus. Then again, ventilation would be difficult, right? If I wanted this side of the lung to be ventilated, and if my bronchial cuff has gone here, this part won't be ventilated. So the bronchial cuff should pass the carina, but it should be above the next division. Might it be right upper lobe bronchus or the left bronchial division? Okay. Next. So what is the depth of insertion is 12 plus height in centimeter by 10. Here are some other formulas. It is a little bit difficult to remember every numerical. So just you remember this one. If you want it for theory part, you can take a screenshot of this. And these are about the sizes in females less than 60 and greater than 60, in males less than 170. So in females less than 160 and greater than 160, and males less than 170 and greater than 170. And this is about tracheal width from 14 to 18. There is no 17. Okay. So techniques, blind approach we have seen, and fiber optic we have seen. So this is fiber optic and this is blind. So how you will confirm? By auscultation, fiber optic, which is gold standard, and by ultrasound. Ultrasound you have to see for absence of lung sliding sign, and there is another sign called lung pulse sign, where the pleural line moves with each heartbeat in a pulsatile manner. Okay. So these two signs you have to see in ultrasound. So this is about auscultation. Let us see the auscultation. See, for suppose This is trachea. Right bronchus and left bronchus. Right bronchus has an opening here for right upper lobe bronchus. Okay. Now I have inserted a left-sided DLT. This is tracheal lumen. This is bronchial lumen. This is tracheal cuff. This is bronchial cuff. Okay. Forgive me for the diagram just for understanding sake. So now let us go for each scenario. First I am inflating the tracheal cuff. Then I have to hear bilateral air entry. If there is unilateral breath sounds, that means I'm hearing only one sided. That means the tube is too far down. This this part has gone in any side. This part has gone this side or this side. The tube is far down. So I have to bring it back. Done. The first scenario is done. What is the second scenario? Now I'll inflate the bronchial cuff. The cuff volume is lesser for the bronchial cuff. So obviously the bronchial diameter is also less, right? So now I'll clamp the tracheal lumen. See, this lumen is clamped. So there is no air entry here. And both the cuffs are inflated. We have discussed this already. The air goes here and it has to ventilate only the left bronchus. So left lung has to be ventilated. Okay. So I have to hear left-sided breath sounds. So what are the other situations? See, if there is still right-sided breath sounds, it means the bronchial opening. This opening is still in trachea. That means the tube is a little bit outside. That means the tube is in this way. This opening is here. This bronchial opening is here. So it is ventilating both sides. So actually I have to hear only left-sided bronchial breath sounds. Now the breath sounds are also heard in the right side. That means the tube is a little bit outside. So I have to insert it inside. So this is the first scenario. Next. Unilateral right side breath sounds indicate incorrect entry. So there is only unilateral right side. First, the actual thing is unilateral left side. If there is both sides, that means tube is outside. If there is only unilateral right side, that means reverse of what has to be done. That means my bronchial, bronchial part of the DLT is in the opposite side. Okay, so there is unilateral right side breath sounds. Next, absence of breath sounds over the entire right lung and the left upper lobe indicates that the tube is too far down. See, there is no breath sounds on the right side. That is what I want. Okay, that is done. But there are no breath sounds in the left upper lobe also. That means this tube, see if this is the upper lobe bronchus division, the tube has gone too far in. So this part of lung is also being not ventilated. So if this is the whole lung, this part is not being ventilated and this part is being ventilated. My aim is the whole left lung has to ventilate and the right lung shouldn't get ventilated. Right here, the right lung is not getting ventilated. I'm okay here. But the left upper part is also not getting ventilated. That means my tube has gone too far in. So these are the variations. Only I have to hear left side breath sounds in the whole left lung area. That is my aim. If that happens, the tube is in right position. If I'm not able to hear upper part of the left lung, that means the tube is too far in. If I'm able to hear right side and also left side air entry, that means the tube is too far out. Okay? Right placement, only left side, whole lung. Too far in, left side, upper lobe, and right side is not, there is no air entry. Too far out, both right and left side air entry are heard. Okay, done. Now, we will unclamp the tracheal lumen and clamp the bronchial lumen. That means we are clamping. This is open. Trachea, tracheal lumen, bronchial lumen, tracheal cup, bronchial cuff. Now, what I'm doing, I'm clamping the bronchial lumen. So there is air entry here. What I have to hear? Check for unilateral right-sided breath sounds. I have to hear breath sounds only this side now. Because the air is going like this and this side air is being obstructed by the bronchial cuff. Okay. Absence or decreased breath sounds indicates the tube is not far down and the bronchial cuff is occluding the distal trachea. So, this bronchial cuff, actually, the breath sounds has to be heard here, but it is not being heard. That means either there is absence or decrease. That means this lumen has to be in the bronchus, but this cuff has to be in the bronchus, but this cuff is being here. That means tube is a little far out. So whatever air that is come, now the placement is, and the cuff is in this manner. So whatever air that is coming here is being obstructed by this bronchial cuff. Only a little air is going. So there is decreased air entry or absence air entry. So the tube is far, it is out. So we have to put it inside. So these are the various positions and the problems with DLT and how you will know with auscultation. So during one lung ventilation, what are our aims? You have to have a lower tidal volumes 5 to 6 ml per kg and the airway peak airway pressures and plateau airway pressures should be less than 35 and 25 respectively, and the respiratory rate is according to the PaCO2 levels. We'll be monitoring the EtCO2. Mostly used mode is pressure control so that there is decreased risk of barotrauma, and FaO2 will be at a lower and required state. Not too lower, not too higher. Okay. This we have already learned. The right side DLT has to have an extra port so that it has to ventilate right upper lobe. So the optimal position of a right DLT confirmed by a fiber optic bronchoscope is the endobronchial side port that we have learned here should be at the opening of the right upper lobe bronchus. So what are the indications where you use right DLT are? We have already learned distorted anatomy of left mainstem bronchus and the site of surgery involving left mainstem bronchus or left-sided lung transplant, left-sided tracheobronchial disruption, anatomical disruption, and left pneumonectomy and left sleeve resection. Now that we are done with the one lung ventilation DLTs, let us go for the second method of one lung ventilation, which is bronchial blockers. Okay, for the bronchial blockers, you have to remember A, B, C, D, E. Okay, first B is for the bronchial blockers. So A is for Arndt blocker. B is for bronchial blocker. C is for Cohen. D, there is no D. E is for EZ blocker. And F is for Fusey block. So, okay, so instead of D, We are going for okay. So and Cohen, EZ, and Fusey blocker. So at least you remember each point for one of these. And blocker has a retractable loop. All these help us to direct the blocker into the specific bronchus. Okay, so if I wanted to block right side, there has to be something which direct my blocker into that specific bronchus, right? So what is Cohen? By Cohen, you have to remember car. So it has a wheel at its tip and an arrow at the bronchial blocker cuff. So that I'll know depending on the arrow and onto which side my blocker has gone. So it has a wheel at the tip and arrow at a more proximal side so that it will direct or it will tell me at which side the bronchial blocker has gone. Next, EZ blocker. See, here are two letters. So let us include another letter to it. Y. So it is a Y-shaped blocker. So it will be something like this. So the end of the Y will sit at the carina and the both ends will go into each bronchus. So it will have two bronchial blockers. So which side to inflate is my wish. So this is about Y shape. Coming to Fusey blocker, it is an independent blocker and it is like a hockey stick. So this is about the four bronchial blockers. And retractable loop. Cohen, you will remember Ka so that it has a wheel and an arrow. EZ, you'll go for another letter. It is a Y-shaped. And Fusey is a hockey stick. Okay. So let us see the diagrams of this. Coming, advantages and disadvantages will be reverse of that of DLT. The advantages of DLTs will be disadvantages for bronchial blockers and reverse. See, bronchial blockers first, and it has a retractable loop. So it will guide the blocker into place. Cohen. So it has a wheel at the most proximal part and an arrow at the distal tip. That means if you see from here, from this side, at the tip there will be wheel. Okay, at the balloon or the blocker cuff, there will be an arrow. So if you see from here, it will be proximal and distal, right? So if you see from here, this will be proximal and this will be distal. So rather than remembering it as a proximal and distal, and remember it as at the tip and at the balloon or cuff. Coming to Fusey blocker, it is an independent blocker and it is of shape of a hockey stick angulation. Last EZ, it is a Y-shaped. So the distal end has a balloon that can be guided into right and left. The end of Y sits at the tracheal carina and each distal end positioned to right and left bronchus and bronchial balloon is inflated in operators. Which side has to be inflated will be decided depending on the side of the lung surgery. So these are the diagrams and retractable loop. Cohen, here there will be wheel and an arrow. And see, this is a shape of a hockey stick. This is Fusey uniblocker and it is an EZ, Y shape. So advantages, what are the disadvantages of the DLTs? Size is a problem. So here size selection is not an issue. So it can be used with regular ETs and post-operative ventilation is also possible. Just we can remove the blocker and the ET tube is already in situ. And lobar lung isolation is possible and CPAP to both the lungs is possible and post-operative ventilation is possible. And it can be used in difficult airways. There, it cannot be used in difficult airways, right? So disadvantages. So advantages of DLT becomes the disadvantages here. Then we need not reposition frequently. We can do bronchoscopies, individual lung suctions and all. Here it is not possible. So frequent repositioning. Requirement of bronchoscope, definitive bronchoscope for positioning, that means for placement of the blocker. And right lung isolation is difficult. There we can go for both lungs isolation. Bronchoscopy and suction to isolated lung is not possible. There it is possible. There we can alternate both the lungs. Here we cannot do that. So what are the complications? During surgery, this blocker might be included in the stitch. That is one complication. The other is the inflated balloon may get repositioned and it can come into trachea. If it comes into trachea, there will be no ventilation because it blocks the passage. So the patient might go into hypoxia and cardiac arrest. So frequent malpositions might occur. So again, you have to reposition frequently. So apart from these disadvantages, where you use bronchial blockers more than DLTs are in the patients where there is previous history of oral and neck surgery and there is a difficult airway and who has undergone contralateral pulmonary resection. Okay. So the third one is the ET tube directly into main stem. The third way of one lung ventilation. First way DLTs we have learned. Second way bronchial blockers we have just learned. Third way is directly passing the ET tube into that particular main stem bronchus. And the fourth is univent tubes. These are relatively easier to insert and selective blockade of some lobes of each lung is possible. And we can also apply CPAP. So coming to post-operative complications, all systems. Cardiovascular wise, there can be arrhythmias, right ventricular failure, cardiac herniation, and hemorrhage. And coming to pulmonary, there might be pulmonary edema. So overly giving fluids in post-operative period will be very much dangerous because in these patients, the pulmonary vasculature will be less distensible, right? So if you give so much of fluid, it cannot tolerate and will lead into pulmonary edema. There might be respiratory insufficiency or pulmonary torsion. And coming to the place where pneumonectomy has occurred, there might be bronchopleural fistula or empyema. And neurological, there might be any nerve injury in and around that surgical procedure place. So in post-operative period, you have to keep the patient in a semi-upright position and you have to support the patient with supplemental oxygen and incentive spirometry should be encouraged and there should be continuous hemodynamic monitoring for sure. Okay. And we have to go for serial post-op chest x-rays to confirm proper positioning of all the tracheostomy drain tubes and all. And adequate analgesia is very much important because the patient might land into respiratory failure if you do not provide him adequate analgesia. Okay, because of pain, he won't take the respirations, right? So the analgesia might be multimodal. You can go for opioids, epidural. For in the mode of anesthesia itself, we have mentioned that others will go for general anesthesia and thoracic epidural analgesia. So we can go for epidural analgesia, wound site catheters, regional blocks, and IV analgesics like ketamine, lidocaine infusions, or oral acetaminophen. So fluid management is very much important because too much fluid will land the patient in pulmonary edema because the pulmonary vasculature is less distensible. And also apart from the vasculature problem, there is due to resection of the lung, intraoperative manipulation, it will impact the lymphatic drainage. So again, there will be fluid accumulation. So it is better to go for invasive hemodynamic monitoring and inotropes rather than excess fluid bolus. And regarding this is a little bit of surgical topic. The chest drain is controversial and it is crucial to maintain in the post-operative period. See, one side the lung is not there, depending on the how amount you have resected. There might be mediastinal shift. If there is mediastinal shift, what happens? There will be hemodynamic collapse. So to prevent that, you have to maintain this chest drain in a proper way. Okay, there should be controlled drainage, not sudden drainage of all the fluid and all. And the clamp removed, the clamp should be removed for 1 minute every hour to assess the hemorrhage. So there will be a drain and the clamp should be removed for every 1 minute to assess. If I open the clamp in such a way that everything gets drained at once, again there will be a shift and hemodynamic collapse, right? So I'll be clamping it and I'll be taking the clamp in a periodical manner and see the amount of hemorrhage and also I will evacuate that hemorrhage through the drain. Okay. And there should be low pressure suction. If you give there is high pressure suction, it sucks all the hemorrhage or air at once and again there will be mediastinal shift. Okay. So this is about one lung ventilation. We have learned the physiology. We have learned the pre-anesthetic checkup And how to attain this one lung ventilation, different methods and different methods of confirmation. We have seen intraoperative complications and also postoperative complications, right? So just read it as a case that you have a case of some bronchiectasis or lung tumor posted for resection. So in PSC, what I have to see in during the preparation of the operation theater, what I have to keep ready, what tubes I have to see, what size, what is the depth, what is the procedure of inserting the tube, whether I'm going for a blind or a fiber optic.